Go ahead and get started. Good morning. Thank you for joining the UCLA HIV Grand Rounds. My name is Oluwadamilola Jolayemi, and I'm with the Center for HIV Identification, Prevention, and Treatment Services. I'm going to go ahead and give a brief overview before we get started with the official presentation today. So just a little bit about the Grand Rounds. Grand Rounds are offered by the UCLA CHIPTS, UCLA-CDU CFAR, and it consists of hour-long lunchtime lectures that are delivered by invited guests and distinguished members of faculty from UCLA and other esteemed institutions. The discussions are on a broad range of HIV-related topics, and the aims of the Grand Rounds are to share the latest research findings on HIV prevention, care, and treatment, and highlight important developments in HIV-related research, to encourage scientific collaborations and networking between UCLA investigators and invited speakers, and to also excite an interest in HIV research for early career investigators and provide resources about new research findings, funding, and career opportunities. So today we have an exciting presentation, and I'll wait on our moderator to go ahead and introduce our speaker. I just wanted to provide some groundkeeping items. We would ask that all attendees please stay muted and use the chat for questions and comments. So during the process of the presentation, you can go ahead and put your comments in the chat, and our speaker will address them as relevant at the point of the presentation. And we also want to ask you that you complete the brief evaluation that will be provided at the end of the chat, so that can help us plan better on our lectures in the future. One last thing that I wanted to add was, these are monthly lectures, and I know that we've had folks who have joined us from the beginning of the year, and this will be our last lecture for the year 2022. We will resume again in January of 2023. So enjoy. At this moment, I'm going to go ahead and introduce our moderator, Dr. Steve Shapter, who is the director of the Center for HIV Identification, Prevention, and Treatment Services. Dr. Shapter, go ahead and take it away and introduce our speaker.
Thanks, Dami. It's really a pleasure and an honor to introduce Dr. Marguerita Lightfoot to you. She's going to be speaking today. Marguerita is a Bruin, so she's from UCLA. I will always count her as a CHIPS member. But she's gone on to do such wonderful work, first in San Francisco and now in Oregon. She's professor and associate dean for research at the Oregon Health and Science University, Portland State University School of Public Health. Prior, she was professor of medicine at the University of California, San Francisco School of Medicine. She's chief of the Division of Prevention Science, director of the Center for AIDS Prevention Studies, CAPS, which is a sister HIV prevention study to CHIPS, and director of the UCSF Prevention Research Center, where she held the Walter Gray Endowed Chair. Her research, and she's a counseling psychologist, and her research interests focus on improving the health and well-being of adolescents and young adults, as well as the development of culturally competent, efficacious preventive interventions for populations disproportionately burdened by health disparities. She has a passion for research that promotes the health and well-being of adolescents and young adults from being disenfranchised populations, and enables them to live their best lives. Her projects examine the intersection of violence, criminalization, and homelessness among youth experiencing homelessness, and she currently has studies to explore providing a guaranteed income to Black youth and interventions to promote whole family wellness in primary care. I think one of the things I do want to say that I love best about what you've started in your career, Marguerita, is your visiting assistant professors program that continues at CAPS, and the ability to provide guided mentorship that's competent for assistant professors, particularly from racial, ethnic, and sexual gender minority backgrounds, is really agenda setting and really addresses the important point that we need mentorship at all points, but particularly when we're in the competition to pass that associate bar. So thanks for who you are and all you've brought to us, and I'm very excited to hear what you have to say.
Thanks, Steve. Thank you for the invitation to be here, and it's really great to see you. Yes, I have been a Bruin, will always be a Bruin. Well, today I want to talk a little bit about some of the work that I have been engaging in my career. and actually tell you a little bit about a journey, about how, well, let me get this to, there we go. A journey that I've been on over the course of my career in terms of the research that I'm doing and the kind of work I'm focusing on. So as you can see here, it kind of presages what my journey has been, moving from this individual focus to a focus on environments in order to really help, in my case, young people to be healthy and happy. So outline for today, I'll talk about that journey a little bit, and then I'll talk through some of my studies so that you can, as a demonstration or illustration for how I've kind of changed my focus over time. So let's start. First off, public health journey. As Steve alluded to, I'm a psychologist by training, which means that I have been focusing on the individual, helping that individual gain skills, leverage their own strengths and resources to be able to deal with any number of situations to help them to be healthy, whether that is HIV, substance use, mental health. And I've been working primarily with young people, and it's been rewarding. And I feel like we've done a lot of important work in the field around helping young people. However, what I realized is that line of young people waiting to be helped, waiting to be involved in my research, never got smaller. So no matter kind of how much I was doing, I almost felt like I wasn't getting at that core issue, the kinds of things that I think are really influencing young people that are really beyond their control. So I really love this quote by James Baldwin, because a lot of the things that I've been thinking about for a long time are things like poverty. But I've always believed, and one of the narratives that I think oftentimes we as researchers tell ourselves is that some of these things are too big and we can't do anything to change them. Therefore, let's just keep focusing on the individual and the person level. And hopefully what I'm going to be able to illustrate to you today is we can't change everything, but as Mr. Baldwin has said, nothing will change unless you face those things. And so I'm hoping to be able to illustrate how I'm trying to face some of those larger structural issues that really are the drivers of people's health as opposed to one's individual behavior. So we know for a long time all of the things that have gone into what makes somebody healthy. What are those determinants for health? And oftentimes we talk about social determinants, but so there's a lot of things that influence someone being healthy. But the thing that's really interesting is that half of what helps someone be healthy, what influences someone's health, is really where they live. It's the environment that they exist in. It's that zip code where they live. Whereas only about 20% of outcomes in terms of health are related to healthcare. Things like what it is that medical system can do, what it is that a clinic can do, what it is that a health provider can do. And oftentimes that's where we focus a lot of our attention. That gets back to that individual health. We focus on that healthcare, we focus on the health behaviors, but we're missing half of what could really influence and help somebody to be healthy. So I've been thinking a lot about this, and you all have probably seen this picture a lot, right? This sense that when we're talking about healthcare, then we're talking about health, not just healthcare, that really we should have a lens around equity, that it's not about everyone getting the same thing. It's that different people need different things. But even my thinking, the thinking for myself and many others has really progressed beyond this, just let's look at equity, right? And so really thinking about social justice. So I think I've spent a lot of my career thinking about how do we help folks who need those extra boxes? How do we help those young people who don't have all of the resources available to them? But really what I'm most interested in is how do we get that wall out of the way to begin with? Like, why do we need boxes in the first place? Can we break down the walls that keep people from being healthy? And so that's what I want to show a little bit of my work and how I'm approaching that question, how I'm approaching the sense of, can we break down barriers? Can we change the structures and environments? And in my case, young people are existing in, so that I'm not just helping a young person deal with their messed up situations, but that we're actually trying to change the messed up situation. So the first study I want to tell you about is a study that we're doing with working with young people who are experiencing homelessness. Steve mentioned this a little bit, really looking at that intersection of homelessness, criminalization, and violence for young people. So the sense of what is happening in the environment of young people that's really causing and driving, in particular, interactions, unhealthy interactions with the police and the justice system, and driving them towards interactions where there's violence involved, which obviously goes without saying is not healthy for anyone. This is a study that we really engage young people as our co-researchers. And so the young people influence our research questions. They collected the data. They were the folks going out doing the interviews, and they also helped analyze the data. The picture on the right shows you some of the work that we were doing collaboratively with the young person in terms of coming up with themes that we were finding from some of our interviews. So in the study, there's 4 components. The first is we had young people who had experience of homelessness themselves or working with homeless populations go out to the streets of, this is a study that happened in San Francisco, and go out to the streets, approach young people and ask them to tell them about their existence. What are the safe and unsafe spaces that they find themselves in? What is driving violence in their day-to-day interactions? And how are they getting their basic needs met? Along with those walking interviews where they tell us their story, they also took pictures of those things that really illustrated the key themes or the key variables that the young people identified as being influential. We also were able to geolocate the data that young people, when they were pointing out to us where they were safe and unsafe, we would use geolocation technology to really map those places. And then the last thing that we did is we collaborated with San Francisco Police Department and got the stop data from the police so that we could understand where, when, and why young people 18 to 24 years of age, the young people that we were working with in this study, why they were being stopped by the police and what happened to them. With the idea that we can then be able to come up with some kinds of strategies, approaches, laws, procedures that really would influence how the systems, how the people who are helping young people interacted with them so that those young people could have better outcomes. So this is a geolocation map. So what you see here is these orange dots are where young people told us that they were experiencing violence. The teal dots are so you can see some teal dots here, where there are places where they said where they were safe. Young people felt that they were safe. And then these dark kind of green dots are where young people said there were services that were available to them. So one of the things that immediately jumped out to us is, as you can see here, a lot of the violence is happening where a lot of the services are. And so we were actually asking young people they had to go to places that they felt were unsafe in order to get the services that they needed in order to help them. And they talked about it being unsafe because there were adults there was substance use happening, there was other violence happening between adults that the young people would get caught up in. So that was one thing that we saw immediately. The other thing, as you'll notice, is all of these dots out here where young people said they were safe is not where services were located. So we were asking young people, San Francisco was asking young people to move from safe spaces into unsafe spaces in order to get the resources and basic needs that they had. Here's a quote from a young person who talked about what it was like to be in certain parts of the city, right? So this sense of being sexually harassed every 5 minutes when they're in this particular part of the city. The other thing that young people told us a lot about was that it was hard for them to access basic needs. The pictures that I'm showing here are pictures that the young people took during these walking tours. So you can see here that a basic need like water that young people didn't have access to, that oftentimes things like getting food, shower, hygiene, using a restroom, water was all really challenging for them to be able to access, and that there were barriers put in place to keep them from accessing, where it's a really clear barrier like this where the water faucet's been locked up, to young people needing to traverse the city to get services, to the service providers are all over the city are providing services at different times. And oftentimes there's no services on the weekends for young people. So here's a quote from a young person where they were talking about this access or lack of access to things that they need. And I would read this to you, but wait, let me see if I can, how do I minimize this little box? Okay, it's not happening. I'm not going to be able to read it because it's covered, but hopefully you're all able to read it. The other thing that young people told us about was that they had to do a lot of work in order to, they felt stigmatized. So in order to just be able to traverse the city, it was a lot of work for them. Oh, here we go. I figured it out. Okay. And so here, this young person, so they basically have to make sure that all of their stuff fits in a small container, so they're not, walking around with shopping carts or big bags of clothing or possessions, because of the way people would treat them. So that folks, people in this neighborhoods would treat them poorly if they looked like they were homeless, if they looked like they were dirty, if they had a lot of stuff. And so they had to do a lot to ensure that they looked presentable so that they could even just go into a store to get services. So as this young person said, if you're homeless and you aren't dirty or unhygienic, businesses tend to be more, I guess, sympathetic towards you. But if you come in and you've got like shit tons of bags and you're nasty and you're dirty, they're not going to let you in their business. Another thing the young people told us a lot about is they felt criminalized just for being homeless. There are laws within many of our cities that really, laws like you can't lay down on the street, you can't lay down on benches, you can't sit for a long time in one place. And so young people talked about being harassed just because they didn't have a place to stay. This is, I think, a perfect example. So this is a sign that is at Golden Gate Park, the largest park in San Francisco. And it covers a couple of miles. And as you can see here, this is one piece of the park called Buena Vista Park, and there's a no loitering sign. And as this young person points out, they put up a no loitering sign at the park. There's a no loitering sign at the park. What the fuck are you supposed to do in a park? Loiter. So this whole sense that they felt like they were being criminalized was very clear. Another thing that we found is that the young people talked a lot about all the different folks who were supposed to be helping them that sometimes weren't as helpful as they would like. Law enforcement was a big one. They talked a lot about the random violence that they were experiencing, having police come in and do sweeps, telling them to move when they're sitting on a bench too long. They can't sleep because a cop will come and try to move them away. So there's this sense that the police were not doing that serve and protect. They actually weren't protecting young people, and oftentimes young people were at the receiving end of a lot of violence that I kind of alluded to with the sweeps that were happening. And then the police would take young people's possessions. And so young people, those little things that they had that they needed to survive were now taken away from them. So as this young person said, police are not safe at all. I went to a police station like 3 times and they were unable to help me all 3 fucking times. So this said, now not all police were like this. We did have young people who talked a little bit about how the police were helpful to them, that there were some cops that helped them. But in general, mostly young people talked about law enforcement hurting more than helping. Surprisingly, we also heard a lot about service providers also sometimes hurting, and that service provider had the sense of they have power over young people. They have the power to provide services, to give access. And so while some of the providers were welcoming, they humanized the young people, young people expressed care, that they felt care from these service providers. They also said a number of them were on power trips. They were mean, aggressive. They didn't allow young people to access the services that were available to them at an agency. They were policing their behavior on a really severe level, and young people had no recourse. So they couldn't really complain about service providers or a counselor or a case manager, that there was nothing that they could do. to rectify a situation. So as this young person said, I only know of a couple case managers that actually do their job and kind of help keep the people safe. And that's only like two case managers that I know of that does that. But those who are like, I don't know if they know what it's like to struggle, but like other case managers, they really are no help. And then just to give you a sense of like what young people are experiencing from the police, we classified the stops into 4 categories. So there's stops that the police indicated were because of some physical altercation was happening. And you'll see here that those kinds of stops were happening mostly in the spring and summer. They happened oftentimes on the weekdays. But the other thing that's really interesting here is that most of the stops, almost half of the police stops, were of Black youth. Now, the Black population in San Francisco is about 8%. And so you can see here the disparity in terms of who's getting stopped for this. The other was property crimes. This was happening mostly in the winter and spring. But again, you can see mostly Black young people and brown young people are being stopped for these crimes. And also males. You'll see at the bottom, there's Bayview, Tenderloin, Bayview. Those are neighborhoods in San Francisco. The Bayview is the predominantly Black neighborhood in San Francisco. Drug possession was another place that young people were getting stopped for. And this is something that was predominantly being, our Latinx young people were being stopped for. But again, another high proportion of Black young people and relative to their population, the representation in the city. And then lastly, young people were being stopped for things like that were related to homelessness. So things like disturbing the peace or prostitution or something like that. Here's the only time where you see females were more often than males stopped, and that was really related to the prostitution piece. But again, you can see that Black and brown young people were stopped the most often. So one of the things, this research was done in collaboration with a community-based organization in San Francisco, the largest one serving youth who are experiencing homelessness in San Francisco. And as a result of this data, we also presented this information, all of this data, to San Francisco Police Department. And as a result of our data, our collaboration with this community-based organization, one of the things that's happening in San Francisco, 2 big things. One is when police stop young people who are in distress, that they don't automatically go to wanting to arrest that young person. They now will call the agency that we were working with. So in presenting this data collaboratively, we were able to really solidify some of those connections between police and service providers. The other thing is that as the city was opening up new housing for young people, because of the data and our collaboration with this large community-based organization, a lot of those new services and new housing, what for young people specifically, was opened outside of that area of San Francisco that I was talking about, that had a lot of services, but also a lot of violence for young people. So we were able to really have an influence on how we were providing services and the kind of the environment in which young people experiencing homelessness were going to have to exist in the city. Another study I want to quickly tell you about is where we were trying to work at the clinic level and community level to increase HIV and STI screening. So this is an intervention that I did in collaboration in San Francisco. This intervention is where we were asking patients who were at the medical clinic. We would approach every young person at this clinic and ask them if they would be willing to message 5 sexually active friends to encourage them to come to the clinic and also get an STI or HIV test. So we didn't tell young people what to say. These were all youth-generated messaging. We did provide them guidance, like, don't piss your friends off, don't accuse them of anything. But really, we were trusting. I trust that the young people know much better what to say to their friends than I do, or even if I had some youth advisory board, that the young people themselves know best what to say to each other. So young people generated these messages. So what we wanted was, in the end, to have 100 young people who sent these messages to their friends. In order to do that, we had to approach about 153 young people. As you can see, most young people consented. Those who didn't agree, those who refused, basically were saying that they didn't have time to do it because they wanted to get in and see their doctor and get out. Those who are ineligible didn't have their phone with them, or they didn't have 5 contacts in their phone that they can connect with. So interestingly, of those young people, that 100 or so who agreed to send out the messages, we asked them to send the message to 5 friends. And what was interesting is that that we had about 1/5 of the young people who sent it to more than 5 friends. So they did more than we asked them to do. And when we asked them why they did that, they said they thought it was important. They wanted their friends to hear. So we didn't pay young people for sending out the messages. We were trying to build an intervention or a sustainable approach that this clinic could use over time. So we did pay young people. We did an interview with them later to try to get at, like, were there any unintended consequences? What did they think about the messages? What did their friends say? Those kinds of things. But so young people were willing to do this, even though they weren't getting paid to do it. They saw the value in it. And so we did pay young people to do this post-test. So we went back a week later to go talk to young people to see what happened as a result of them sending out the message. So just to give you a sense, young people, we did some content analysis of the messages that all the young people sent. So because young people were sending out the messages while they were at the clinic, we were able to capture the messages they sent so that we could do some analysis of those. We also, if they got a response from their friend while they were still in the clinic, I mean, most text messages, I read somewhere that we read our text messages within something like 8 seconds of receiving them. So if they received a response from the friend, we also recorded that. But in classifying the messages that young people sent, not surprisingly, most of them could be classified as like a call to action. They were telling their friends to do something. So are you having unprotected sex? You need to come and visit the 3rd Street Youth Clinic. That's the clinic that we were working with. Here's the number, do it right away, make an appointment. So they're telling their friend to do something. Another example of that. The other thing, not surprisingly, is that most of them were personalized messages. So we asked young people to send messages to 5 friends. They didn't send one message to all 5 friends. They sent 5 separate messages, a personalized message most of the time to each of their friends, a different message to each of their friends. And that message was often had something to do with what they thought their friend needed to hear, or about something they knew about their friend and their status. Oops. And then the other thing that we saw was, not surprisingly again, that most of the messages contained some clinic information. So the young people were telling their friends where to go to get messages. Oftentimes they were like, it's right next to the wing stop, or giving them some other information about the clinic. Here you can see they were telling them the ages and what kinds of services that they were providing. And then lastly, because young people were at the clinic when they sent their message, about half of them actually talked about their own personal experience being with the clinic. So they disclosed that they were at the clinic at the time that they sent the message, that they were getting services from this clinic, and that the clinic was cool. So here's another example. This young person talked about, hey, I went to this clinic. They were really helpful. They were supportive, to get over this sense that young people might be resistant to coming to the clinic because of the way they might be treated. Okay. As I mentioned, we also were able to capture responses that young people received right away from the messages. And you can see here that in general, young people, the responses that they received were relatively positive, anywhere from, yeah, are you okay? Because I'm like, well, that's kind of random that you sent me this message, to like, I got it, I'm going to go, thank you for the information. When we went and talked to young people a week later, we asked young people like what their concerns were about sending the messages. Did their friends and them talk about the messages after? Did we kind of cause any conflict within their friendships? We wanted to learn about all of that. And what we heard was young people weren't worried about sending the messages. They felt comfortable sending the messages for the most part. There was some little concern about what their friends would say. But more concern actually about what their friends would do. Would they actually listen? Would they come to the clinic? Would they do what they were trying to influence their friends to do? So there was a big component of that. And then young people also told us that they didn't talk about the message after it. They sent it, and the next time they saw their friend, or the next time they had a text conversation, or the next time they were in the group chat, it never came up again. And so it was like they sent this message. There was a lot of fear around would we be causing conflict by asking young people to do this? And we didn't see that happen at all. So the question is, so young people were willing to do it. So now the question is, did it make any difference? So here you can see we used a design where we were following the clinic for some period of time, which is on the left-hand side, that purple line. And then we started providing them, having young people send the messages, and that those green lines are what happened after we started having young people send the messages. So you can see here, there's a trend that more young people, the clinic itself was detecting more positive STI tests, that more of the young people that were coming to the clinic reported high risk. And by high risk, I mean they were either had an STI, they had multiple partners, or they didn't use condoms regularly in their self-report during their intake. The clinic also was able to see higher levels of HIV. I'm not entirely sure what that one spike is, but in general, the trend was more that more of the patients that they were seeing they were able to show HIV as well as STI. So it really accomplished the goal that the clinic had, which was to get more young people into the clinic who they felt were at risk, because the clinic was talked about that while they knew that they were seeing some at-risk young people that felt like they weren't, that there was probably many more young people in the community who were engaging in risk behaviors who weren't coming into the clinic. And so so this strategy was really intended to address that concern of the clinic, to get more young people exhibiting risk into the clinic. So because of this success, this is really the basis of, now we did this intervention in a place where mobile technology is ubiquitous, right? So you think about, in the United States, every young person has a phone. Well, you talk about some place like many of the countries in Africa, there's not even a landline. So if you have a phone, it's got to be a mobile phone. And in fact, many countries in Africa have more mobile phones and more mobile phone users than they do in the US or Europe. So it seemed a natural progression to test out the strategy and approach in an African country. So I partnered with a adolescent medicine clinic in Zimbabwe. Here just gives you a sense of some of the messages that the young people in Zimbabwe sent. These are translation of messages. This was all done in Lugandan, or not Lugandan, in Shona, which is the language in Zimbabwe. And so here, again, we asked the young people to do the same thing. Can you send a message out to 5 friends? Can you encourage your friends to come into the clinic? Some of the primary differences that we observed between what was happening and how this rolled out in Zimbabwe versus the United States is, in Zimbabwe, young people, remember in the United States, we had about 1/5 of young people send more than the 5 messages. In Zimbabwe, young people sent the 5 messages that we asked them to. They also were more likely to send the same message to all friends, so to all of their 5 friends. So it was less targeted than what we saw in the United States. And then in the US, young people were using their cell phones, they were using SMS to send messages, whereas in Zimbabwe, it was predominantly young people chose to use WhatsApp to send their message. So again, we looked at some of the data to see what kinds of changes that the clinic saw in their patient population over time. Here you can see before, that purple line is before messaging started, then the messages started, that red line is what happened in terms of patient reports through the intakes, patient characteristics after we started the messaging. As you can see, that purple line, when we talk about the number of new patients who were coming into the clinic that were testing positive for HIV, that tapered over time. But when we started doing the messaging, that jumped, and then that trend continued, where more and more patients were coming in that were HIV positive. And so in fact, what we saw was a doubling of the number of new patients coming in and who were tested for getting tested for HIV. Similarly, when we looked at the number of patients who were testing HIV positive, as you can see, again, that purple line was kind of flat. But we started doing the messaging, we saw an influx of patients who were getting the testing. We were identifying more patients who were HIV positive, and that stayed at a higher level than before the messaging throughout. So we saw like a 5 times higher onset, or 5 times higher level of a number of patients who were testing positive for HIV than before the messaging started. Then again, when we looked, same pattern, when we looked at the number of patients who are indicating that they had sexual risk, that they were coming in for they had symptoms of an STI, less so testing for STIs, because testing wasn't happening there. So symptomatology for an STI, whether or not they had multiple partners and they were using or using condoms inconsistently. And again, here we saw that before the messaging started, the clinic was seeing risky patients, but that was starting to taper off. Once we asked young people to send the messages, that jumped up and we saw a continued increase. So there's 3 times the number of patients with reporting sexual risk once we started the messaging. So here we were able to really mobilize the community of young people and their social networks to get HIV and STI tests or HIV testing happening at a significant rate. So it was an approach that really seemed to make a difference. And it's an approach that at both clinics, both the one in San Francisco and in the one in Zimbabwe, are continuing to use. Lastly, I want to briefly just tell you about a couple of new studies that I have starting up that, again, kind of speak to the sense of are there ways in which we can think about how to change the environments that young people exist in to help them to be healthy? So the first is increasing financial and health equity for low-income Black youth and young adults. And in this study, what we are doing is really thinking about how do we increase the economic capacity and give young people a head start economically, because we know that poverty is at the basis of so many of the negative health outcomes, that no matter how you slice and dice it, no matter what age, no matter what city, no matter what gender or sexual orientation, no matter what, poverty is really a significant driver. And so we were thinking about, well, is there something that we can do to address poverty? And the sense, and we know that there's some data already, research has happened, especially in HIV, where this idea of giving cash transfer seems to be a positive or a strategy that seems to be working. So the sense of, can we do that cash transfer in a way that doesn't have conditions, so that it's done so that we can provide funding on a consistent basis, and it's not going up and down depending on what the life circumstances are for a person at any given time. And this idea of giving this guaranteed income as opposed to a conditional income allows young people that flexibility to be able to make decisions. It provides and opens up the space for them to not just survive, but think about how can they thrive, that freedom to just make decisions for themselves, as opposed to someone coming in telling them what they need to do in order to be able to move forward. And so I love this quote because it really is at the foundation. Oftentimes we hear that what people need to do if they're in poverty is pick themselves up by their bootstraps. They just need to work harder in order to make money. And the reality is, as I'm sure many of you can appreciate, it's not really about how hard you work, that there is so much more that goes into whether or not someone can succeed than one's bootstraps and hard work. And so the premise of this study, we're in the middle of it, is that we were going to provide a guaranteed income to young people. And it's based in real solid science around guaranteed income for adults. We know that in guaranteed income programs for adults that participants report reduced anxiety and depression. We know that they're doing more things, they're going to classes, they're trying to find better jobs, they're investing in their future, and have the thought to do that when they have that space to be able to get their basic needs met. And we also see with adults that health-seeking behavior, service utilization, are more likely to go to the doctor's appointments, go to dentist appointments, go to other kind of healthcare things, actually get the medication that's prescribed to them if they have that kind of guaranteed income. So we know that works in adults. We're not so sure what it might do and how it might help young people. And we're focusing on young people 18 to 24 because that's like the emerging adulthood. That's when a young person is quote unquote independent. And I say that in quotes because up until a year ago, my 22-year-old son still lived with me. So we know independence is relative, but the sense that they're thinking about their future, they're laying the foundations for what they can do in order to reach their dreams in the future and to be financially stable. And the other thing that's really exciting about this project is that it has real policy impact. There are a number of pilot projects that are happening around guaranteed income, whether you're talking about Jackson, Mississippi, or New York, New York. They're happening all over the country. And so, but oftentimes they're not done with a rigorous evaluation attached to them. And so we'll be able to really talk about what kinds of outcomes can we expect, particularly for young people when it comes to providing them this baseline of income. So our outcomes for this study is financial well-being. So are they more likely to go to school? Are they taking some kind of training? Are they taking the time to find a better job? What does their mental health look like if they're getting a guaranteed income? And by mental health, we're looking specifically at depression and anxiety. And given the age that we're working with, young people 18 to 24 years, what you need them to be able to do is definitely accessing sexual reproductive health services, as well as utilizing mental health services if they need it. So really looking at whether or not providing that guaranteed income allows them to do that. Now, the reality is we're talking about young people, right? And so we want to be able to give them some scaffolding to be able to make decisions about their funding. So while it's not required, we will be providing additional financial capability supports for young people. And we're wanting to see if actually providing that, do young people access those services? Because remember, the income is guaranteed. They don't have to access the services in order to get the income. And those who access it, does it help them to really accelerate more than just providing the guaranteed income? So we've partnered with a community-based organization that's providing financial coaching for every young person in the study who would like it. And they're what are called peer learning circles, where there'll be education around financial literacy. And the reality is, and we're focusing on Black youth in particular because the legacy of institutional racism really kept Black folks from gaining and building that generational wealth. And I can even just use myself as an example. My parents didn't buy their first home until they were in their 40s. And so in the United States, the way people build wealth is through home ownership. And if folks aren't able to buy homes and aren't understanding how to build wealth over time, then it's going to be really hard. That drives some of that intergenerational poverty that we often see. I mean, I can convey stories of not knowing what estate taxes were, not knowing what capital gains were. Like, I'm learning all of this stuff, and I'm a highly educated person with lots of resources. So we need to be able to help young people understand finances, understand how to make money work for them so they can reach their own goals. So how are we doing that? So in order to be part of this study, young people have to be, as I mentioned, 18 to 24. They can't be part of any other guaranteed income program. They also have to identify as Black, because I had mentioned that we're wanting to focus on Black identified youth. We want to make sure that young people are living in the United States for at least 3 years. And that's really about, have they had more likely to have had the experience of this economic inequity and racism that Black young folks will have to oftentimes experience. And then they also have to, one of the things that we struggle with is, how do we decide who is low income? Do we check young people's salary? Do we look at their pay? Like, how do we decide? And so the thing that how we decided was that they have to live in, by HUD definition, a low income or very low income census tract in San Francisco or Oakland in order to be eligible for the study. So how are we working this? We're randomizing young people to either receive the guaranteed income right away or to not receive the guaranteed income right away. Everyone is opting into those financial capability trainings that I mentioned. Then we're going to do a crossover where the young people get the guaranteed income for a year. We're providing them $500 a month for a year. And then those young people who, for that year, they're serving as our control group for a year, so we can compare them with the young people who are getting guaranteed income. But after that year, they also will get the guaranteed income. Morally, working with our communities, just ethically, it didn't feel right to have some young people get money and some young people not get money. So that's why we've done the design in particular. That's driven our decision to make the design this way. But it also now allows us to find out what happens to young people once we stop giving them the money. What happens to their mental health? What happens to their financial plans? All of those things we'll be able to really monitor for another year after a young person stops getting the money. The other thing that we're going to be doing is we'll have a subset of young people. We'll be doing qualitative interviews with them. Of course, we're going to be doing quantitative surveys with young people every 3 months. So we'll have a lot of data. All of the young people will be getting the quantitative surveys. A subsample of young people will be getting an in-depth qualitative survey over time. So we'll have a lot of information to help us understand what's happening. So we are in the middle of recruiting for the study right now. As you can imagine, there's a lot of demand. And so we've had to come up with some ways in which to make decisions. So for example, we opened up, we had to think about, like, how do we decide who to give this money to? Is it the first come, first serve? So that those who are most connected or hear about something first? We didn't think that was right. And so we are doing this drawing where young people identify themselves online, they fill out an interest form, then that interest form can determine whether or not they're eligible, and kind of initial eligibility. We call back every young person that initially comes back as eligible, and then we do a drawing in order to randomly choose which young people get the funding. And we'll be doing successive drawings so that folks have more than one chance to get some of the funding. And as you can imagine, like, we just started recruiting a month ago. We opened up the website and we had over 1,200 young people fill in the interest survey. And so it's exciting that we have these that we'll be able to really have reach a whole lot of young people. It's a little frustrating that we're only able to take 300, but we're also able to connect young people with some services as well. And then no one said this work was easy. And so even you would think that giving young people money would be really easy to do. And so just to give you a sense of some of the things that we've had to encounter in doing this is, one, how do we keep young people from being taxed on their money so that they end up with a full $500 and not have a bunch of income tax taken out, or that they have to pay income tax on the money at the end of the year? We've had to go around and around in order to ensure that. How do we make sure that young people who are getting public benefits, we're working with young people who are in low-income settings, that are getting CalFresh, that are getting all kinds of services? We want to make sure that their benefits are not taken away or jeopardized. And so we had to go through a whole process with the state to get an exemption so that the money doesn't count against their public benefits. The federal benefits are another question. And so young people who are getting federal benefits like Social Security, we've arranged for those young people to talk to benefit lawyers to help them decide whether or not they want to be in the study or not. And then you're giving young people money. There's likely to be partners, parents, relatives who are pressuring them about what to do with their money, how to share their money, and all of those things. And so we're really thinking a lot about how to mitigate some of those risks and help young people to be able to cope with those challenges. But no one said this work would be easy. But hopefully at some point in a few years, I'll be able to tell you what we found in this study. Another study I want to tell you about quickly is a whole family wellness approach to how we work with young people who are in primary care. And so what we know is that more than 2/3 of young people have experienced some traumatic event by the time they're 16, and that traumatic event is likely impacting their health, which is why they show up to a primary care setting to begin with. However, our health system is so fragmented and not really coordinated, so that we talk to this young person over here, and what's happening with their family over there isn't even really addressed. And so maybe what a young person needs to be healthy is that their father gets treatment for their depression, or their brother has a job, or or we help that family who's on the verge of being homeless. So really thinking about, well, in primary care, we have a patient, this young person that comes in, but we can't look at that young person in a vacuum without considering other things. And we have a actually unique opportunity now in California, because some of the policies for reimbursements have changing that might allows for more of this flexibility for clinics to not just work with that one patient and think about like, what services am I providing for this one patient, but also take into account the family and the ecosystem that that young person exists in. So this whole family approach is what we're building. So we're trying to build a model by which we could implement some kind of whole family approach. So we're in the middle right now. These are the aims for the study, where we're going to explore what clinics are currently doing, how they interact with families. Clinics that are working with adolescents in particular will co-design with a clinic an intervention or an approach, a program that can be implemented in the clinic that really addresses and centers the family as opposed to just the individual patient. And then we'll look to see, once we've developed that approach, implement that in the clinic and see what we find. Is it feasible? Is it acceptable? Does it work within the workflows of the clinic? Are they able to reimburse for those costs? How much does it cost? All of those things. And so really this whole idea of working with the family. And so we'll be doing a number of things to develop this intervention. We'll be talking to adolescents, we'll be talking to their caregivers, we'll be talking to families holistically and doing some echo mapping. We'll talk to community partners that work with clinics, because oftentimes clinics refer out. So we're looking at like what kind of network needs to be built in order for a whole family approach to be taken. And then we'll also be talking, of course, to the clinics themselves, the frontline staff, the providers, the behavioral health staff, to understand how they're working now, how they think about families, what it might look like if we were to take a more family-based approach, a family-centered approach in primary care, and really think about not just trauma, but also what are the strengths of the family? What are the things that are distressing that family right now, as well as what has happened to you that might have caused you trauma that is now influencing likely some of the health outcomes that you're presenting with in the clinic. So all of that, the last thing I want to leave you with is, what about HIV, right? So a lot of the things I've been talking about are poverty, our primary care, our police and criminalization. What does that got to do with HIV? Well, I hope that you see that has a lot to do with HIV. Let's go back to this picture that I showed earlier. Oftentimes in HIV, we are focused on that 50%, right? We're talking about access to care. We're looking at the quality of care. We're looking at how do we get people on PrEP? How do we get people tested? How do we make sure that people are engaged in care and taking their medications and doing their treatments? We are missing the other half of the equation that really influences a person's ability to do anything on the other half. And so going back to this, like, we know what oftentimes some of these social determinants of health are that influence HIV. We're talking about stigma, poverty, absolutely. All of these things that oftentimes that I've been talking about have relevance for HIV. When I was talking about the guaranteed income, I could easily be talking about, let's look at HIV risk behaviors as an outcome for that, as well as income and mental health. We need to be working at some of these other levels in order to actually have an impact, I believe, on HIV. And we've had some impact, but it's limited, I think, because we've only been working with half of the person and half of the equation. So I'll end with kind of what the title of my talk is. Can we change conditions and not just individuals? And I say the answer to that, and borrowing from James Baldwin, is yes. We just have to face it. Thank you so much for your time and your attention and this invitation. And I'm happy to answer any questions.
Thanks, Marguerita. That's a tour de force. That's amazing. And seriously, I took a bunch of notes. We have a question in from Paula Tavro asking, saying it's a great idea to use youth as text messengers. But she had a question about, like, at the clinics, are there young people who can act as peer patient navigators or peer counselors once the youth show up at the clinic following the texts?
Yeah, so actually at the piece I didn't talk about in the study in Zimbabwe is what happens to the young people who test positive. And we are also evaluating qualitatively a strategy where young people are connected with peer navigators once they test positive. And so those peer navigators take the young people, walk with the young people, accompany them to go to the site, to go to the clinic that's looking at, they call them OI clinics in Zimbabwe. So all that HIV care, getting young people confirmatory testing, getting them on medication, talking about disclosure, how they're going to tell their families, all of those issues. Then these peer navigators not only help make that transition, they check in with the young person on a weekly basis, just to, in the short term for 3 months, and then ongoing after, so that they're always available to the young people that test positive. So there's definitely, that model is being implemented for sure. And I think and there's a lot of data to suggest and really support this idea that peer navigators, even young people, are critically important in helping young people to maintain access and sustain care.
Awesome. I had some other questions. First of all, your incentives work is brilliant. I love that idea. You know, everybody has a fundamental need to pay the rent and to eat on a regular basis. So it's like the idea of being able to address that as a place where you start with health is really, really fantastic. In the US, I mean, I've seen it in other countries, and I've seen some mayors doing this, but this is really fantastic. Who is your funder for that work?
The NIH.
Congratulations.
So we got funded through the NIH's transformative interventions to address health disparities, something like that. So kudos to the NIH for wanting to, they had a whole different kind of review process as a way to seed new innovative ways to address health disparities. So our project got funded. There was a project that is looking at taking young people into hikes as a way of addressing disparities. So a whole number of different things, but a new, NIH is looking to do some new investments in how they address these issues. So I encourage folks who have big ideas to not rule the NIH out.
Yeah, I'm blown away. That's really remarkable. I will say, you know, we are at this point today on day 2 of the strike of all of the GSRs, the TAs, and the people who are laboring at less than living wages here in Los Angeles and other parts in the UC, where you know, apparently we can't build academic elitism without free labor. It's an American tradition, but at any rate, it is going on, and it is a demonstration that even among us very privileged people to be accessing the academy, that we have to address these problems, and I really appreciate you raising that within our communities as well. What is the situation that you find? Your landscape work was really, really remarkable, and I hats off for doing that lovely landscape work. But what is the situation post-COVID with access to HIV prevention supplies, in testing and prevention supplies out there in our communities? So you talked about where resources are, but you know, now after COVID, the resources have been leveraged for other things. Storefronts have gone away. Street outreach is largely unavailable here in Los Angeles. But what's it like out there that you're seeing in your work?
Yeah, I think that's actually kind of universal. I've seen agencies close. They weren't able to survive the pandemic. I've seen agencies who, because of COVID, were unable to do their usual activities like outreach and all of those. And so now they're just trying to staff up to be able to engage in those activities again. There's an incredible need around mental health, and there's just not the workforce. Agencies are desperate to find social workers, counselors, therapists to help them. So like, that's the immediate need. And then once you can help deal with that, then you can get to the, now can we get you in to get testing? Can we get you in to get other kinds of medical health services? And so agencies, my experience has been that they're having a heck of a time just meeting those basic needs that they're seeing coming, flooding them at the front door. So there's fewer agencies to do it. There's not enough people doing the work. And so it's not surprising the kinds of things that you're talking about, Steve, where there's lack of access, that there's, it's hard to get to places. It's hard to find the area, the place, you know, those street fronts that you used to be able to see, or that mobile van that you used to be able to go to just doesn't exist anymore. And so it's much harder to kind of navigate the landscape in order to access the services that you need.
Yeah, that's really ironic because among transition aged youth, those are the people who are having a lot of sex. You'd really want to be able to have those resources available to
Absolutely.
those people. So it's on us.
Absolutely.
Yep.
Yeah, let alone what's happening at the societal level in terms of how we're thinking about women's health and women's autonomy.
Yeah, I'm still furious about that one myself too. So thank you so much. This is like a blow you to the back of the theater presentation. I'm glad that you were here to tell us about the work you're doing. This is truly agenda setting. Thanks for being with us. And I owe you dinner next time we see each other. So in person. Okay, awesome.
All right, thank you.
All right.
Take care.
Thanks much.
Bye.